terms of the database, so you can compare yourself to other organizations by name. So you could look at Brigham, Mass Gen, anybody else that you want to look at that's in the tool. The exceptions to that are patient identifiable information, so you can't go in and see Brigham's patients, and you can't go in and see Brigham's physicians by name. So if you were given access to internal BU physicians or BMC physicians, you would be able to see their information by name, but that's a level of security that Roshan would decide is appropriate for you.
Thank you, guys.
Thank you.
So, just brief background. Are folks familiar with UHC at all, or do you guys get a rundown ahead of time at all? So just for background on what UHC is in like the early 80s, a bunch of hospitals in the Midwest got together and decided to do some group purchasing together. So they decided like it would be cheaper if we go and we purchase our gloves together or whatever. So that sort of started the UHC story, where then a couple years later they said, well, we should probably do some quality metrics together too. And so that sort of continued over time. And so now UHC is a much bigger group. We do the group purchasing stuff as well, but then we have a bunch of clinical data products. So the one that I'm going to show you today is the clinical database and the resource manager. But we also have one called FPSC, which is the Faculty Practice Solution Center. So that's all of the when you hear of sort of the physicians that work for the group practice, that's all of their data. Sometimes those are linked up with the hospital, sometimes they're not. It sort of just depends on the agreement that folks have internally. There's the operational database, which is Action OI, if anybody's worked with any of those products. That's that piece. We also have some stuff tied to the nursing program. So we have a nurse resident program and a nurse use the NDNQI data. So when you're applying for magnet status, that type of information. I'm trying to think if I'm forgetting any of them. Oh, and safety intelligence. So safety intelligence is an incident reporting system and patient safety organization. So if you had a patient that fell in the organization and you needed to report that for patient safety, either claims or complaints type of information, you could do all that through that system as well. And then there's sort of some back-end movements to try to link a lot of that data together. So can you start to compare stuff that you see in the clinical database to things that were internally reported already at your organization and start to link them all together in ways that are more efficient than the way we currently got it. Most of what you're going to want in this tool is based on having a login to the tool. There's some stuff that's publicly available, but because we're a co-op, we don't really have a need to be sharing things externally. So like some of our competitors will have stuff that if you just like Google a study that they've done, you might be able to get that study just by finding it on the internet. For the most part, our stuff is going to be behind our firewall just because it's supposed to be a member-owned organization. The other nice thing about being a member-owned organization is that we're driven by what our members want. So if you guys had some enhancements you wanted to see in the tool, I don't know if they'll actually come to fruition in the time frame that you're working on them, but share them with us. If there's something that you don't like about it, let us know, and we vet all of those things and eventually change the tool based on what the users want it to be like. The other nice thing is that you own all of the information in UHC, so if you want to know exactly what goes into one of our risk models, for example, nothing's going to be proprietary. If we own it, you own it, we can tell you everything that goes into it. So we risk adjust for things like mortality, length of stay, and cost. If you want to know what were the specific ICD-9 codes that made up a variable that influenced risk of mortality, we can get down to that granular level and give you all of the statistical models behind it if you should ever need anything like that level. But we're here to help if you need any of that stuff. Logging in is like logging into every other thing you've ever logged into. If you need a login, click request a login. They're going to bring you through a few questions you have to answer. Then an email will get shot off to Roshan, and he'll approve your access or deny your access or question your access based on whatever it is you're trying to work on. I would assume since he was integral in setting this up that he's expecting those types of emails from you guys.
If you do request a login, though, just let me know also so I can give Roshan the heads up that you're on the council and he should approve it.
One other quick note is it's uhc.edu, not uhc.com. If you go to .com, you'll go to the insurer. We're not the insurer. We have nothing to do with them, so we're completely separate, so it is a .edu address. So main homepage is where you can get on any of the councils and collaboratives or any of the list servers. List servers are things like, hey, I'm trying to do a study on XYZ. Is anybody else at your organization doing something similar? Some of the list servers are extremely active. Some of them are less active. As you go through and add yourself to list servers, be careful, because if you add yourself to like every list server, the ones that are really active will inundate your mailbox with a ton of emails, and you'll probably just delete them all and not want to be on the list server anymore. So be wary. Don't add yourself to everything. Just add yourself to the stuff that you're interested in. Education and events are all self-explanatory. The ones that you're probably going to be most interested in are the clinical database and resource manager. So if we just go over here and click this, the layout of the tool is pretty simple. You'll see a bunch of yellow tabs up at the top, and I'll walk through what most of them are. I'm also going to do this really quick and then save time for question and answer at the end, and so we can go back through and highlight things in more depth. Major announcements are going to be here on the homepage, so if we did a data freeze or something like that, we would let you know what was going on there. The Learning Center is probably the most important link that I'm going to show you today, just because that's where you can go in and get all of that information that I was telling you about. So it's right on the main homepage of the clinical database. If you click the Learning Center, it's going to open up a bunch of different links, and there'll be things like on-demand videos, this talk that I'm doing, but for like 3 hours rather than for 45 minutes. Any of the documentations that have to do with the risk models, or how do we calculate readmissions versus how do other people calculate readmissions, that type of info will all be in the Learning Center. I should also slow down and tell you that the way we get your data is that it's submitted to us monthly by Roshan Shop. It is ICD-9 based for the most part, but with a bunch of other demographic pieces of information. We also link it up to your core measures information, NHSN information, so that's things like infection control info. I'm trying to think what else. We run it through the risk methodologies, we add readmission info to it, and we add in all the AHRQ quality metrics. So like things like PSI 90 or any of your patient safety indicators will also be in here. The important thing to note, because it'll come up, is that it's an administrative database for the most part. We are adding in clinical values as well, but because everybody's spending most of their time converting to Epic right now, people are not spending most of their time figuring out how to get certain lab values out of Epic or whatever. So as we're adding things, or as we can get IT time from people at the individual hospitals, we're asking them to add stuff to the data feed, but so far the major infrastructure issues, if you're implementing a $300 million system, that's probably where you want your IT resources to go for right now. So we're working on ways to get data out of those systems that won't involve your IT group, but we're not quite there yet on that. Data's clean. I won't bore you with all of this stuff, but essentially we run 1 million checks on your data to make sure that the data is accurate and coming through, down to we had a person that was the registration specialist at one organization, came on and really didn't like asking people their race, and so she would check other every time she checked somebody in, and because we run analyses on their data, we were able to see that their demographics were drastically changing from 1 month to the previous year. So we were able to contact them and get them to change her behavior when she was checking in patients, to let them know that stuff like that is important in our data sets. So there is a lot of stuff that we check on here, really basic stuff like, did you remember to send us your codes, but also really pretty advanced stuff to make sure that the data is clean. There is a download data option. My guess is that they won't grant this access to anybody other than Roshan, because it's a download of your entire data set back to the hospital, and so that's that guy's worst nightmare. It just left just because it's a huge data set that somebody could theoretically put on a thumb drive and lose, and then you'd be in a real mess. So I'm probably not going to bother with that, but it is something that's available if you should need a huge data set of every patient that's ever been at BMC. You could start to look into that, but I probably wouldn't suggest it right away, because there's plenty to do in the tool before you get there. The top 10 reports for other hospitals I like to point out, just because these are the reports that people are running across the country. It's almost always a patient outcomes report by hospital, because that gives you risk-adjusted mortality, length of stay, and cost. But a same report, patient outcomes by ARC Safety, gives you all of the PSI measures. And so I'll get into what that means, but when you get into Report Builder, all that person had to do was change one drop down and they get a drastically different report. So if you run these top 10 reports, you'll get an idea of what other people are using the tool for pretty quickly. So that's the home page. The Learning Center is really the most important piece of that. The download I mentioned is individual pieces of everybody's data, so you usually need an analyst to make sense of most of that data. The sort of drastic opposite of that is the Report Express area. That's where we've already done most of the work for you and put it into dashboards for you to play around with the different data pieces. The middle ground area is Report Builder, and that's where we'll end up right after this. I'll show a couple of these, but I won't spend tons of time showing them all, because they're basically all the same thing but for different things. So I'll just sort of mention what's in each report, and then if you want me to open up any of them, I'm happy to do that. Vitals and Performance is our balance scorecard. So there's going to be a bunch of top box metrics and then ability to drill down into each one of the metrics. not for this piece, but in Report Builder you can. So like, that's the really unique thing about UHC is because we're a collaborative. I always joke that it's the only place in Boston that I hear collaborative, not competitive. And so like, most of the time, people actually work together on these things. So if you ever need to get in touch with the residents at Tufts, if we have that ability to connect you, we're always happy to do that. We work with most of the hospitals in the country that are relevant to your group. So this target's set to best decile, so you're gonna see red, but that doesn't necessarily mean it's a bad thing, because best decile would mean that you're in the top 10% on every metric compared to every academic medical center in the country. So most people are in the red for many of these metrics. Roshan can change this target, but he's probably the only person that can. The reason I bring this up is just to show you a couple of things, just because it sort of shows some of the generic things that people are looking at around the country. So we got feedback from all of our members when we built this dashboard to make sure that it would meet most of their needs. So it's someplace that if you were just getting started, you could maybe, like if you just wanted to start to think about inpatient mortality, you could go here and click inpatient mortality index. The bottom piece is looking at your observed ratio to target. It'll show you your rank overall, the cases, and then opportunity. Opportunity is going to be calculated as whatever the thing is if you moved your observed rate to target. So if it's mortality, it's lives. If it's length of stay, it's days. If it's readmits, it's less readmits. There's also a second level of drill down. So if we click this piece, it'll show you more information. You can pop this graph out, export it to image, and then put it in a deck if you wanted. The nice thing about that is none of this is going to like open yourself up to PHI. So this graph has already been created. It's not. You can put that in a presentation. You don't have to worry about does it meet PHI rules, because we know it does. Any place you see a hyperlink though will get you to the patient level. And so that's when you start to get into the PHI piece. So if you see hyperlinks, that means you've been granted patient level access. If you click that, it's going to bring up a spreadsheet that has all of the patients that are included in that metric. So that's the thing you don't want to put on a flash drive and drop on the bus or something. We also give you related metrics, and we also will give you definitions and how to review. The reason that I'm really pointing this out is that some of these metrics, if you're doing a study that you only have like 3 months to get something done, or you're going to be doing this for a little bit, but you're not going to necessarily be in the tool all the time right away, because we've already created the metrics for you, we'll give you what all of the inclusions, exclusions are. So if we were in readmits, you could look at AMI, heart failure, pneumonia readmits. In that definitions and how to review will be all of the ICD-9 codes for heart failure, pneumonia, AMI, so you don't have to go find that from your coders or any of that stuff. It'll already be there for you.
Would you be able to look at readmits for like other subspecialties,
Yep.
i.e. stroke?
Anything.
Okay.
Yeah, so anything that has an ICD-9 code, a DRG, a specialty, so you can look at physician specialties or you can look at service lines. Service lines are defined by DRG, specialties are defined by you at your hospital.
And the readmits, they will not give the age number or the name or age and.
So they would ultimately, I'll run one in Report Builder.
Okay.
Report Builder is where you can really start to chop data however you want it, and it's probably the piece that you guys are going to be most interested in. I just wanted to show the canned reports in case they're useful.
One other thing, with the rank, what's that out of?
So it's out of whatever this is. So all AMCs is academic medical centers. So this would be the rank out of the academic medical centers. So your observed mortality rate is 37 out of 121 maybe or so. And then it's based on, so in this one, it looks like your observed rank is pretty low or good. Your expected rank, so what that means is, are you getting credit for how sick your patients are, essentially? So either there's a coding and documentation thing where you're not getting enough credit in our models, or you don't have very sick patients, which we know isn't true at BMC, so we would probably start with looking at things like coding and documentation. There's going to be related metrics to this, so I mentioned in readmits it's going to be heart failure, pneumonia, whatever, but there'll also be things like where did the patients go, did they go out to a SNF, did they get discharged home, so that type of info. Looking at your returns to ED will be in there too. I'm trying to think what else we have in the readmits. Oh, breakdown by 7-day rate. So that's another thing that I found with one organization that was kind of cool was if you looked at readmits for this one hospital, they were ranked like 1 in the database, but the proportion of their patients that came back within 7 days was last in the database. So when we actually drilled into their data, readmits for patients discharged on Friday was twice the rate of any other day of the week. And so they were able to go and see whatever their process was on Fridays. Were they rushing the patients out? Were they just more likely to readmit on a Sunday versus a Monday or whatever it was? But you see kind of interesting things in there. So vitals and performance, it's all going to be the same thing. If you click one of them, you'll drill down into the more in-depth one. I'll just sort of hover over this for a second so you get an idea of what's in the tool, but the other piece, the report builder, is probably where you're going to spend a lot of your time. Quality and safety management is going to be the ARC measures and hospital-acquired conditions. Clinical outcomes report is going to be your risk-adjusted mortality by service line. Hospital quality measures report is going to be all your core measures. And then resource manager reports are all going to be your resource type measures. So in the canned reports, it's going to be all pharmacy. In the actual tool, you can look at things like blood utilization, lab utilization, radiology utilization, all of that type of information. That's probably most of what you care about here. There's some clinical documentation and coding reports, but probably not relevant to you all. And then the Q&A study scorecard is the what we put out every year. It's our top 10 list of AMCs. We sort of joke that it's like the U.S. News and World Report, except we use data. And so ours is very similar. It's going to be a ranking of the top 10, but it's based off of actual metrics that you can drill down into, and you can see how we've created it. All of the methodologies are published online, so you can have all of them. And then there's a calculator that's new that'll show you that if you were like to improve certain measures, how you would impact your rank in the overall study. So BMC's actually done really well and improved quite a bit since Roshan's been here working on these types of things, especially in mortality. He's had quite a bit of improvement. So if you looked at that over the years, you would see that you all are improving quite a bit. So Report Express is where you'd get all of your generic reports. Report Builder is where you'd actually get your drill down reports. And so this is the place that you'll probably spend most of your time if you're putting these together, if you're not able to find what you need in Report Express. The way you write reports here is just clicking, I want to look at patient outcomes, what do you want to see it by, and then what time frames. This is how you would select which hospitals you're interested in. So if you clicked Boston Medical, yours will default here. But then in Hospital Profiler, you can select different ways to pick the hospitals. So here's all the U.S. News and World Report hospitals, top 20 pediatrics, America's Essential Hospitals or NAPH hospitals, so that's your group. We've got CHA hospitals, Partnership for Patients, just a ton of different groupings that we've pre-selected for you. You can also customize those lists. So if you close out of here, you can just select them here and then save them as a custom list. Then you can add standard restrictions and advanced restrictions. Standard restrictions are really just there. I don't tend to mess with them unless I'm running a readmit report. There's one standard restriction in readmits that I flip from related to all cause, because most people are mostly interested in all cause. But other than that, the standard restrictions are there because the stuff that would be included in your data set, if you change them, isn't something you're interested in, because like you don't want bad data in your data set, so we just automatically eliminate it for you. Advanced restrictions are exactly what they sound like. So what do you specifically want to or not want to see in your data set? So if we go up here, we could say, I want to see things by hospital. And then in the advanced restrictions, we could say, but I only want to see general surgery. So if we go to Hospital Profiler and just pick like New England hospitals. So this over here is the ghost box. I think that they named it after the Super Mario Brothers ghost because it follows you everywhere, but no one seems to be able to confirm that for me. When you run the reports, there's a bunch of ways to run it. So this is tabular. This is the one that I'll show you. I'll click this one, and so you'll see what that one is. Excel will export to Excel, PDF to PDF. The two friends is the sharing icon, so you can share both internally with each other, or you could share back to UHC. So if you were trying to run one of these reports and you weren't getting what you were expecting and you wanted to know, like, what am I doing wrong, you could share it with me. I could take a look at your report, we could have a quick call, and then I could share it back with you so that you have the thing set up the way that you want. The other thing is if you're doing general surgery and somebody else is doing neurosurgery and somebody else is doing pediatric surgery, but you're all basically writing the same thing. You could just share the one report with all of your colleagues. They could change the advanced restriction to be the thing that they want, and you would all be running the exact same reports just for different service lines or specialties. So if we run that report, maybe. Oh, that's never good. It tends to run the fastest when I'm in front of a big group of people. Alright, let's see if it goes this time. Sometimes on the first time you run a report in UHC for whatever computer you're using, the pop-up blockers that you all have on your computer start to interfere with our database, and so sometimes you have to reset it, re-log in, and then come back. It should only happen the first time you do it on a given computer, but it does happen. The other thing is it should be really fast, so if you're ever not getting fast results, let us know and we'll figure out what's going on. We switched all of our servers, so things were running like things that took 45 minutes take 4 seconds now, and so it shouldn't ever really be slow.
So you're saying we can't see the patient level identifiers, right?
So right here you cannot. So this is all of the general surgery patients from each one of these individual hospitals with their length of stay, mortality, complications, ICU, et cetera, et cetera, et cetera. Anytime you see a hyperlink though, if I click that, it would drill down to the patient level. So I'm going to avoid doing that just for the sake of not capturing it on film. But you could do that for sure. And
So for BMC, I'll have that access, that I can see individual.
if Roshan grants it to you. I presume he would because
Okay.
that's why he probably had the PHI talk. But yeah, you would. And the thing with that is you could then put it in Excel and you could then put it on a flash
Yeah,
drive.
yeah.
So we generally recommend keeping it all in the tool.
Right.
But there'll be times where you need to throw it in a pivot table or
Like
something
Twitter,
like
Twitter
that.
would be okay.
Yeah, Twitter's fine. Especially with a picture. I really like that. So, for example, if you wanted to know who were the 8 cases that had complications or whatever number, you would click that, it'll drill down, and we call it sort of the mini medical record. It'll be a little profile that'll have all of the information that's in the thing. And it's like tons of information, so every ICD-9 code. One that he didn't mention that comes up sometimes is zip code. If it doesn't usually tend to be a problem in Boston, but in like rural Nebraska, if you have the zip code and you know that they had a heart transplant, it's pretty fast. You can pretty quickly identify who that human being is, and so things like zip code got added to PHI as well, so you have to be careful when you mess with zip codes. Length of stay I mentioned is all risk adjusted, mortality is risk adjusted, complications are not, readmissions are not. For major readmissions specifically, because we don't have enough information to risk adjust. So the thing that the event is the readmit, especially in a place like Boston, you could get discharged from BMC and readmit yourself at Brigham in like 5 seconds, and we wouldn't be able to know. Well, we might be able to, but we can't share it with you that the patient migrated from one area to the other area. We're working on doing things internally, so if you worked in a system, you would be able to see the patients bouncing around your system, but so far we HIPAA is sort of behind on that piece, or we're behind with that piece. Trying to think. There's a ton more stuff I can tell you about the database, but I just really wanted to introduce you to it today. So I'm going to hover over some of the drop downs just so you can see like all of the different stuff that you can cut this up by. So if you found something like the basic way that I would start with that report is I'd run a report by service line. I'd start to see, okay, which service line seems to have the biggest problem with mortality. Then you can start to drill down into that and say which of in that service line was there a particular DRG that seems to have the most problems, or a particular set of patients that has the most problems. And you could do all of that by changing each one of these group bys. You can also click multiple group by, and then you'd have, so by hospital, then you'd have by service line, and then you could even do by, say, discharge physician. And so then you could save that and then run the report so that you see everything by individual physicians. or you could do it by day of week, you could do it by really anything you can think of, it's probably in here, and then you can cut the data differently to impact your data set that way. Physician Insight I'm not going to bother with just because I doubt you'll probably use it, but it's essentially the same thing except that it's all by physician, so it's a way that you can go in and run reports and see all of this information by individual physicians. Most of the time that's going to be coming out of your quality group, so I can't imagine that you'd be using it for that, but if you ever need something like that, I'm happy to do a one-on-one or come back or something and talk about that a bit more.
Could you do an example for like running UTIs on a certain service?
Did you say UTIs?
Yeah, like for example.
Yeah, so if we did, I'm trying to think, I think UTI is one of the ARC measures. So if we did, let's say, UHC service line by HRQ safety. This is the really lazy way to do this. There's also a ton of ICD-9 codes that are for UTI, and what I would do is I'd just call my coder and find out what they are. I don't know them offhand. So you could do it that way, but I think that there's a, like iatrogenic UTI might be a PSI, so I'm trying to see if I can grab it that way. You can save all of these too. That's another thing. So if you're setting these up, you don't have to set them up every time. You can just save the report using the really modern 3.5 floppy disk over here, and just save that as whatever you want it as, and name it. The other one was schedule. You don't really need to schedule them anymore because that was a function that we needed when reports took 40 minutes to run, because nobody wanted to sit and watch it spin for 40 minutes. But now that you don't need to do that, you probably won't have any issues with that. So puncture, laceration.
This is given in monthly chunks.
You send it to us monthly, but you can set it up so that you could see it however you want. So if you wanted to see it by month, by quarter, by year, and it goes back 3 years, I believe.
Can you create like comparison? Can you designate, I want to see June and then I want to see December? And you can say that specifically.
Yeah, definitely. Yep. So there is not one, but I think I've got another one over here. So here's the hospital-acquired UTI in the VIP. So what I would do is go here, go to definitions, how to review, and then find .99664. So with UTIs, you have to use present on admission flags, which you may or may not know about just because of coding, but especially if you're just trying to find all UTIs, you just put in that one code. If you want to find the UTIs that happened after the patient arrived at the hospital, you would want to put in UTI not present on admission, so that you only get the ones that occurred in the hospital. If we add the restriction of diagnosis, I'll do any diagnosis just for the sake of this. You don't need to put the dots in. You can, but you don't need to. So this is where you'd apply present on admission flag. I'll just leave it all just for the sake of demonstrating.
All you have to do is check that though.
Yeah, it should be pretty easy to do. Yeah. So here's all the patients that had a UTI while they were in the hospital. So if you wanted a rate, you would just run the original report without the UTI, then that'd be your denominator, and then you'd add with UTI, and that's your numerator.
If we only want to look at our service, like we don't care about the others.
Yep. So what are you?
Ortho?
Yep. Add restriction. again, there's two ways to pick this. So if you wanted to use DRG ortho versus specialty, so ortho's funny because there's ortho by specialty, and then there's people that are having orthopedic type stuff, and maybe the ortho wasn't involved. That maybe not with ortho, but sometimes you see it like cardiology patients that only the hospitalists touch. Anyways, there's a couple different ways to do it, and each one has their benefit. But if you just wanted to do service line of orthopedics, do that, and then it's going to restrict it down, and now the only people that will pop up are the orthopedic patients.
And that's based on like the attending? So
No, this one's based on the DRG that the patients were placed into, with a couple of like caveats. So ortho, we took out the patients that have major trauma and are here because they're like crushed and had an ortho procedure. But so there's some logic behind that, but for the most part, it's based off of DRG. If you only wanted to see the patients that were treated by an orthopedic surgeon, you could do it by physician specialty and switch it so there were no UTIs according to this in the service line, but you could go and do. That's
Probably weren't taking care of
Awesome.
this.
If we do,
Neurology does the same thing.
No,
Well,
it's
it's
not-
a
it's not
UTI,
a-
it's not a
It's
stroke.
not a medicine. It's surgery you guys are taking care of.
so we'll find them hopefully this way.
So it seems like we're gonna learn through a lot of tinkering with this. And
Yeah.
as long as we don't drill down to the patient level, we're not accessing any protected health information and we can run wild.
Yeah, exactly. So there's little bits with that. Like, so things like, if you started to cut this data apart using all of the restrictions I'm showing you, like that thing that he was saying about the 3 identifiers, you
Right.
might be able to get close to having 3 identifiers. So you could get, but there's no maliciousness there for the most part, and so most likely, that's not the criteria for HIPAA, but I doubt you're going to set off any super flags if you don't drill down to the patient level. Like I said, maliciousness isn't necessary. The intent, I don't think, is relevant to HIPAA at times, but you're probably not going to get yourself in trouble by doing it this way. I'm not a lawyer. That wasn't legal advice.
One of the challenges that just the fact that when you ran the first report, I'm one of the OB residents, when you ran that first report that we didn't come up with any, and I know for a fact that we have had them. So how do we know that the data that we're running is actually correct?
Did you say you were OB?
Yeah,
For which one?
for like
What was
catheter
the-
associated UTIs. I know we've had them on our GYN service, and so how do you know that when you're running a report that you can trust that it's actually giving you the right information?
Yeah. The best way is to find one, whatever the real life version of it is, like in the hospital, or find one that you know from M&M or whatever it is that where you say you know that you had some. Either you've seen it because you treated the patient, or because you've talked about it in some quality meeting. Find that patient, and then you would go in and see how they're coded in UHC and see what it did or didn't set off. Because some of those indicators, like ARC indicators, are set up to be very, very specific criteria. Some of them are only going to be hospital acquired. Some of them are going to be like based off of this very explicit definition of whatever. So we can find ways to back into it too. Maybe there isn't a generic national indicator for it, but you can still find it. I do it by.
Are there any BMC patients that aren't in here?
Anybody that's inpatient for sure will be in here. Outpatient, it sort of depends how you're sending us the information. So,
Does that include emergency visits or do those go in?
if you're sending us outpatient information, which I can check pretty quickly to see if you are, the ED stuff will be in there. The problem with that is that the classification stuff is different, so you then tend to get more into patient level data, because there's not an AHRQ metric for the ED yet for this type of data set, and so you'd have to go in and sort of start to tinker and create your own types of things. Okay.
And it's okay if we get the patient level data, as long as it's what we're supposed to be looking at.
Yeah,
right?
exactly. Okay. Where would they be? because I was using the wrong one. So does that look better? Or not better, but more accurate? So it was 5.9, I was using the wrong code, I only used there's two of them, and I was only using one of them. Much more believable.
I don't know. Must feel like the blue come out of the unit.
They all have
Oh
foliage.
my god, there's 3 digits there. Technology might have 3 digits.
No, we do. We have 111.
Yeah, but then, I mean, it's relatively low
What's ours?
application.
Yeah, so that was a year's worth of data. I also didn't apply present on admission, so they could have come in with a UTI.
Oh,
So
yeah,
there's
we
a
got
lot of
one
things you
those.
could tinker with to change this to get
I
it
mean,
right.
it's all relative. It's not percentage of your patients.
Yeah.
It's just total.
Right.
What's the parenthesis next to it?
Parentheses are length of stay outliers, so patients that stay longer than, I think it's 98% of all other patients in that DRG.
Oh, we got a lot of those.
It's just a matter of time.
No,
before
you
they
only
get
have
UTI.
4 of those.
That you measure
Yeah.
in years.
A few of them died. That's why. Oh, you've got one person who's been here for 3 years. So.
Are there other questions at all? I worked with a surgeon that was trained here and then was over at Newton for a long time, and so he taught me a lot of this stuff. The first thing he told me was pick a project. Don't try to learn the actual database. Try to find something you want to figure out. That would be my advice to you. So like even UTI, we could talk. I could get 5 other people that only work on UTI. That's their specialty in the database, and so we could like pair you up with that person. They could tell you all of the things that they ran into, why you want to use this flag and not that flag, why you don't want to forget one of the codes that is really important to this metric. So there's like lots of things that we can provide help with. If you pick something, just let us know, and I can connect you to the right people at the at our organization or the right people here.
How do we contact you?
Leave cards on the table.
So I guess going forward, as we all try out the database, are you the best person to contact with questions about like reports, or who do you want us to contact?
So cdpinfo@uhc.edu is the help desk that can triage everything. They are probably the place that you'll get the fastest response. I will also help triage. If you're ever not getting a response from anybody, email me and I'll make sure that it gets to the right people too. But they've been great. We actually just hired a really, really good person that's been doing a great job over there.
What is it again?
CDP, so cat dog person, info at uhc.edu. We picked a lot of letters that sound very similar, and so it's easier.
All right, well, thank you very much for coming.
Awesome.
You guys
Thank
really
you.
awesome.
Thanks, everybody.